So, who is responsible for obtaining the informed consent? So, it is the ultimate responsibility of the primary investigator, but everyone involved in the consent process must be trained and also competent to perform their specific role. So, the evidence of the consent training must be obtained in addition to maintaining competence and keeping updated in regard to the processes for the ethical considerations, and the person obtaining this informed consent must be updated or knowing the protocol of the procedure, and it can in some cases be a delegated task. So the participant information sheet is a version controlled, approved version and dated of the consistent format with a localized logo, and it shouldn't change unless there is a minor typo. And also, it should include the contact details for the investigator teams. So we need to document everything in our research project, including the date and time, the patient identifier number, and verifying all inclusion and exclusion criteria with the patient information sheet that is given, and also clarifying when to follow up and when it will take place. So we must give adequate time to consider, as this may be specified in the protocol. It will also be governed by the study protocol requirement, and it should be specified in the IRS application form and must take into account the patient time frame. So some of the problems that we can face with a consent include the vulnerability, the conceptual understanding, having corrosion in some cases, time pressure, or even not an event, but it can be considered as a process. Also, it can include non-eligibility, responding to an expressed preference to an arms, and breaking bad news, then recruiting the patient to the participant. Also, family preference or conflict can affect the patient decision. So, in the case where we have adults who are lacking the capacity to make their own decision, they can be presumed well in some cases, and this can be different between clinical and non clinical trials. So, in the Mental Capacity Act that was developed in 2005, so the person must be assumed to have the capacity unless it is established otherwise. Also, individuals should be helped to make their own decision as far as practicable, and a person is not to be treated as unable to make decision merely because of their unwise decision. And all decision and actions must be in the best interest of the persons who are lacking the capacity. So all decisions and action must be at the least restricted for the person right, as well as to have their own freedom of action. So, does the Mental Capacity Act apply to the clinical trials of an investigational medical product? This is not true because they are specifically excluded from the research provision of the Act, and this is because of the separate provision that is made for including adults lacking the capacity in clinical trials. So there are some differences between clinical trials and non-clinical trials in regard to the ethical consideration that we need to follow or the regulations. And these can include having some professional representativeness or a nominated consultant. So in the case of choosing minors as representative in the clinical trials, those under the age of 16, their parent or someone who has their parental responsibility can agree on their behalf, or having a personal legal representative, as well as we must ensure that the parents or the legal representative understand that we are asking them to give a consent for the minor, also understand the objective risk and inconvenience of the trial, as well as the conditions under which it is to be conducted. Also, they should have been informed of the right to withdraw the child from the trial at any time in the research project. Also, they have a contact point where further information of the trial can be obtained. So, in summary, historic events have shaped the regulation of research involving human subjects, and this has led to the introduction of the GCP regulations and the governance procedures for research. Also, research ethics, ICH, and good clinical practice in the policy framework for the health and social care research are in place to ensure that the protection of the right, safety, as well as the well-being of the research participants. An integral part of conducting research is having the ability to conduct critical appraisal. So, in the evidence based medicine, it is defined as the consistent or the continuous of the explicit and justice use of the current best evidence in making the decision about the core of the individual patients. So, it means the integrating of the individual clinical expertise with the best available external evidence from the systematic research. So there are different categorization of the clinical trial or the research designs in which clinical trials or the systematic review of randomized clinical trial is regarded as the strongest evidence that can be obtained, while the weakest type of study designs is the case report. So what is a systematic review? Systematic reviews are scientific investigations in themselves, and they synthesize the result of multiple primary investigations by using strategies that limit the bias and the random error. So these strategies include a comprehensive search of all potentially relevant articles and the use of explicit, reproducible criteria in the selection of articles for review. So the primary research designs and study characteristics are appraised, and the data are synthesized, and the results are interpreted afterward. So how is this different from the normal literature review? Literature reviews are usually the one individual opinion that is the current state of knowledge. and this is inevitably limited and form a practical perspective. So combining results can increase the beware of the precision of the estimated effectiveness. And when there are few or no studies found, this can be helpful to pinpoint the crucial areas and questions that need further research. So the process of a systematic review starts with a question, followed by checking the need and stating the objective and the criteria, followed by the search for the studies, assessing for inclusion, having a data set, and using meta analysis or subgroup analysis, and then constructing a structured report of review. So, how can we decide if this is a good systematic review? We need to ask the question of, did the review ask the clearly focused questions? Also, how well have they searched for all of these studies that may be relevant? In addition, how will they have studied or have been filtered to select those that meet the reviewer criteria? Also, has the quality of the studies been assessed? And how well have the results been combined? And what were the results and how precise were they? So, effects of review can affect, for example, the SWOT evidence that has been interpreted in various studies. So, this review on the effect of salt in reducing the blood pressure and CVD has been interpreted to suggest that although that salt is important predictor of blood pressure, advice to reduce salt is not very effective. So this supports the current UK move to work with the food industry to reduce the salt in food, and the effectiveness of this has not yet been rigorously tested. So when we are pooling our data, we only combine the numbers from studies that we believe to be asking the same question, and sometimes the studies can appear similar but give very different answers. So we need to look out for this in performing meta-analysis. So this can explain the heterogeneity in assessing the odd ratio for some studies. We'll be taking a break for Salat al-Maghrib and then continue our discussion. Assalamu alaikum wa rahmatullah. Welcome back, everyone. So, as we have discussed previously, the different type of issues that can result with the sample size calculation, we will continue our discussion with heterogeneity. So, there are also some statistical tests that we can use to assess for heterogeneity. These include the chi-square test and also having a p-value of less than 0.10. So might not be appropriate in all type of data, and the most used measure is called the chi-square test. So the I2, which describes the percentage of the total variation across studies due to heterogeneity rather than the chance. So a value of 0% indicates no observed heterogeneity, and a larger value to show increasing heterogeneity. So we can see in this analysis for the effect of salt reduction on systolic blood pressure, we can see down below the test for heterogeneity, which is the chi-square test value and the overall effect for the value. So if we find heterogeneity, we don't need to meta-analyze the data, but we can explore the causes for this heterogeneity through subgroup analysis. So we can also always use a narrative analysis as a method for assessment. Also, there are some grades for the clinical significance of the systematic review that need to be assessed. These include assessing the quality of the evidence, as how confident we are in the answer provided by the review, such as high, moderate, low, or very low. Also, the grade assessment is the summary of, do we believe that the results from this study is valid, risk of bias? Also, if the results are consistent across the different studies, and to assess for the inconsistency. And we need to ask, are all of these results of these studies published in regard to the publication bias? Also, is this effect of the size precise? And assessing for the imprecision, and how do all of these results apply in terms of their directness. So the Cochrane Collaboration is an international nonprofit organization that prepares, maintains, and also disseminates the systematic up-to-date review of healthcare interventions. So mainly, but not exclusively, it will review randomized controlled trials, and it will support the systematic reviewers in assessing for their studies' strength. So the best sources for SRs are the Cochrane Library, and it can be a database for studies of abstract review of effectiveness, including the controlled trial register. So Cochrane wider role plays an important role in training and supporting the systematic reviewers, increasing the number of systematic review in clinical areas, developing methodology, and producing systematic reviews that are updated consistently. So overall, a good systematic review can inform our own clinical practice individually and via guidelines, inform the research agenda, and are considered the best place to look for evidence and can be useful and well-cited publication. So this is a brief interview of the systematic review in the Cochrane Library. So one of the major categories of research studies are the quantitative research. So quantitative design is based upon scientific method and uses deductive resourcing, and researchers from hypotheses collect data in an investigation of the problem. After that, it will use the data from the investigations, and after the analysis is made and the conclusion are shared, this will prove the hypothesis that if it was true or rather false. So there are 4 types of quantitative design, including experimental studies, comparative, correlational, and survey studies. The experimental studies are often called true experimentation, and it uses the scientific method to establish a cause-effect matter relationship among the variables in research study. So researchers can make an effort to control for all variables except for the ones that are being manipulated, which are the independent variables, and the effect of the independent variable on the dependent variable are collected and analyzed for assessing their relationship. So the major feature that distinguishes experimental research from other type of research is that the researcher can manipulate the independent variable as much as they like. So it can also be subject that are randomly assigned to the experimental treatment. So experimental design should be developed to ensure internal and external validity of the study. Regarding the internal validity, these are the result of the study caused by the factors that are included in the study. So they are caused by other factors that are external variable, which are not part of the study. So internal validity are unwanted variables that can, external variables are unwanted variables that may have an effect on the experimental outcome. So if we are worried about gender, for example, we only include one gender in the study to avoid this type of observation being valid. So it can have some threats to the internal validity, and the subject characteristic includes selection bias, and the groups may have been different from the start to the end. And if we were testing for instructional strategy to improve the reading, and one group can enjoy, for example, reading more than the other, then they may improve more in their reading capabilities because they enjoy it, and this can be affecting the internal validity. Also, in regard to location, perhaps one group was at a disadvantaged location because of their location, for example, and the city could, for example, have been demolished in buildings while the location was far away from them for the follow-up. Also, for the instrumentations, the testing of the instrument may not be scored similarly, and perhaps the person grading the post-test is fatigued, for example, and pays less attention to the details as the reviewers. Also, for the data collection, bias, these are the person who are collecting the data and may have some favors for one group rather than the other, and therefore will lead to selection bias. So for the resentful demonetization of the control group, these can become discouraged because it is not receiving the special attention that it is giving to the treatment group. Therefore, they may form a lower than the usual because of this selection bias. So once the researchers are confident, then the outcome of the experiment are designing the result of their treatment and the internal validity, They can therefore determine for which people or situation the result of their study can apply externally. So in the external validity, these are defined as the results of the study that are generalized and can be applied to other populations and settings. So it can come in two forms, the population validity and the ecological validity. For the first one, the population validity, this is the extent to which the results of the study can be generalized from the specific sample that was studied to the larger group of subjects. While for the ecological validity, this is the extent to which the result of an experiment can be generalized from the set of environmental conditions created by the researcher to other environmental conditions, the settings and the conditions as well. But there are, of course, some threats to these external validities, including the pretest sensitization, as a treatment may only work if it was pretested, and because then they would be giving a pretest, the subject may be more sensitive to the treatment, and had they already taken the test, the treatment wouldn't have worked. Also, there is the measurement of the DV, in which a treatment may only be evident with certain types of measurement, and a teaching method may produce superior results when its effectiveness is tested with an assay test. But it can also show no differences when the effectiveness is measured with an MCQ test. So first and foremost, an experiment must have internal validity, and if the researchers cannot be certain that the results of the experiment are dependent on the treatment, it doesn't matter to which people or situation they wish to generalize their finding. So the importance of this external validity is relating to having internal validity in much of the same way that the validity of the measurement instrument is reliant on the instrument being reliable. And there are, of course, some different research designs, including the one-shot case study design, or one group pretest or pretest post-test design, the static group pretest design, and a lot of different randomization tests that can be conducted for assessing different factors. So, why are animals used in the drug development procedures before it is implemented or tested on human subjects? This is conducted to understand how a drug behaves in vivo because it can capture the pharmacokinetic data and assess for toxicity in addition to assessing for efficacy. And for the pharmacokinetic and the toxicity data, it can measure the exposure at different doses, assessing for the absorption, the distribution, and also metabolism and excretion. It can also define the tolerability and the safety with the maximum tolerated dose, the well-being, and the tissue damage. So it can be used in the duration of repeated dose toxicity studies to support phase 1 and 2 trials in Europe and phase 1, 2, and 3 trials in the US and Japan. So having a repeated dose preclinical studies will commonly have 3 doses level and a vehicle. So a low dose should be non-toxic, but small multiple estimated therapeutic doses should be included. Also, a high dose should be sufficient to cause toxicity, but not death. And having an intermediate dose can be included to assess for the lowest dose that can be included. So some of the common terminology we are going to be using is the NOEL, which is the non-observable adverse effect level, also the HED, which is the human equivalent dose, the MABLE, which is the minimum anticipated biological effect level, and the MRSD, which is the maximum recommended starting dose. So the NOEL is the highest dose level that doesn't produce a significant increase in the adverse effects in comparison to the control group. And it can refer to the biologically significant rather than statistically, as it doesn't have to be statistically significant. So it can distinguish from no observed effect level, which may be effective in animals that are acceptable, and lowest of the observed adverse effect level in human studies. So there are essentially three types of finding in non-clinical toxicology studies that can be used to determine the NOEL. The first is the overall toxicity, such as the clinical signs. Also, there is the surrogate markers of toxicity, such as serum liver enzyme levels and the exaggerated pharmacodynamic effect. While for the human equivalent dose, this is after the NOEL and the relevant animal studies that have been determined, and they are converted to the HED. So HED assumption is that toxic endpoint for the therapeutic administered systematically to animals, such as the MTDs, are usually assumed to scale well between species when doses are normalized to the body surface area. So HDE is calculated from the NOEL in the most appropriate animal species using the body surface area conversion factor. And the most appropriate species is usually the most sensitive, but occasionally another model is more relevant. So converting to mg and MQ meters for the head measurement of the converting dose, we need to first convert an animal from mg to kg to mg per meter squared. So the dose is multiplied by the conversion factor indicated as kilometer. And then the dose can be converted back into mg per kg in human by dividing that dose by the Km factors for humans. So converting to mg kg per h in a single step can be calculated directly from the animal dose by dividing the animal dose by the ratio of the human animal Km factors. And these are pre-decided here in the table, as you can see, depending upon the dose. We will follow this by applying a safety factor, in which the safety factor should be applied to the HED to increase the assurance that the first dose in human will not cause any adverse effect as a result of human bioavailability, and metabolism may differ significantly from that of animals. So mechanism of the toxicity may not be known, and the toxicity may be due to an unidentified metabolite, and also the toxicity may be difficult to detect in animals. And for the MRSDs, in general, one should consider using a safety factor of at least 10, and dividing the HED by the safety factor will give us the MRSD. So the reasons to increasing the safety factor include inadequate dose response data, a novel therapeutic target, animal models with limited utility, and having a steep dose response curve, a severe toxicity, or even toxicity without any premonitory signs, and any other large variability in the dose or the plasma drug level. And for the efficacy studies, we need to ask the questions: is there any single signals of desired effect? And also, we need to ask: does it rely on animal models of disease of interest? So, why does animal studies fail to predict the efficacy in humans? First of all, animals are not miniature humans, therefore, there are differences in the metabolic pathways and the drug metabolites. So, inadequate knowledge of the cause of a disease mean it is difficult to reproduce the human condition. Also, differences in the route and dose of administration compared to the human, and the lack of robust study design, methods of randomization, blinding, and the choice of conversion of the therapy can be indicated. So, a small experimental group with inadequate statistical power, simple statistical analysis that doesn't account for confounding, and failure to follow the intention to treat the principles. Also, using outcome measures of uncertain relevance to the human clinical condition, and animals don't report subjective effect. Also, the variable duration of follow up, which may not correspond to the disease latency in humans. In addition, it may need to humanize the animals for some treatment. So, this is the reproducibility of most medications, and the factors contributing to this can include the selective reporting, low statistical power, insufficient oversight or monitoring, or method unavailability. So, to improve the bioscience research reporting, the ARRIVE guidelines for reporting animal research has been conducted for each study design, including the experimental procedure and choosing the appropriate experimental animal in assessing for the disease severity. And there are some alternatives to animals, including an induced blueprint of the stem cells, in addition to creating on a disease and an isogenic background. Also, having an organ on a chip with combining cells type on a scaffold. Also, in the in silico studies, by computer models of disease, networking of the medication, and etc. Also, we have using the human as an experimental subject in the microdosing phase, in the pharmacological challenges or imaging studies. So, for the critical appraisal, this is an evidence based medicine to assess for the variabilities and can include, as we have mentioned, the hierarchies of the studies and the clinical review assessment. So some of the statistical methods that we can use to analyze the data include the statistical inference. So this is defined as the interpretation or conclusion from a given information or premises. So we can define statistical inference to be the derivation of conclusion from information of the data using a statistical method and principle. So we can define the statistical inference to be derivation of conclusion from the main principles, and one of the most common of these principles is the significant testing. So when we are assessing continuous type of data, we will be using t-tests. T-tests are used to make inference about the mean values in a samples of continuous data. So we can use these tests to make inference about the mean values in a single sample or differences between mean value in a sample of data from two different groups, or about the mean change from the baseline in the paired type of data. So t-tests are based on mathematical models that assumes the underlying continuous measurement have a normal distribution and are conversions of data from different groups. The simplest test assumes that the variance in these two groups is the same. So one sample t-test usage in some experimental situation, it can have a set of observations of continuous data collected from a single sample of subjects. So in such cases, our interest generally lies in making inference about the mean value of the population from which these observations were drawn. So we can commonly ask ourselves whether the true mean has a certain pre-specified value or not. So these types of inference can be made using one sample t-test. This is an example of data using biomarker measurement in a single sample of population. So if we have a sample result from 12 samples, we can, for example, test the null hypothesis that the true mean is equal to 10, and we will use simple program written using R program to analyze our data. So in the one sample t-test, we can use the two-sided test using R, which will give us the result, as you can see here. But it will mean that the p-value is higher than the conventional level of 0.05. We have interpreted this to mean that these data are consistent with the null hypothesis that the true mean level is equal to 10. So this was regarding the continuous data. But if we have a paired type of data, this is for the continuous measurements that are recorded before an intervention is applied at baseline and then at a follow-up measurement on each subject made after the intervention. So in this case, we are usually interested in making inference about the change in the mean from baseline to the post-intervention period. So we could quite simply subtract the baseline value from the post-intervention value, and then we would have a single set of difference observation, which could only analyze or be analyzed as a single set of values using the test just described. So this is an example of paired t-test, including baseline measurement and post-treatment measurement. And if we were to analyze these data using our program, then the result would be that the p-value is higher than the conventional level of 0.05. Therefore, it would mean that these data are consistent with the null hypothesis that the true mean difference is equal to 0. So these for the paired analysis using R, and having an example of this is assessing the thyroxine level before and after CST. So to interpret this result, it would mean that the thyroxine level post the scan are significantly lower than the pre-conditioning. While if we were using a two-sample t-test, It can be used in continuous data with samples that perhaps come from different treatment groups or different patient subsets. So we can use a two-sample t-test to make a conversion of the mean value in the two groups. And if there is a no genuine difference between the two groups, then the true difference between the two means is equal to 0. So the t-test can be used to assess this null hypothesis. This is an example if we have a measurement of a biomarker value of two groups, each of 10 subjects. So we can use a two-sample t-test to compare the mean values, which are the null hypothesis that the true mean difference is equal to 0. So we would interpret this to mean that these data are consistent with the null hypothesis that the true mean difference is equal to 0. And to interpret these results, for example, if we have the time of the neutrophil engraftment that is 2.1 days, long for patients receiving a graft from unrelated donor when compared with sibling donor. So for the continuous data, we would use the Wilson rank sum test. So some t-tests can make a number of assumptions about the data that are being analyzed, one of which is that the underlying value have a normal distribution. So if we have reason to doubt the validity of this assumption, we can use the Wilson rank sum test to make comparison between the two groups of continuous measurement. Also, this test is an example of the non-parametric significant test. Such tests can make very general and widely applicable assumptions about the data that are given with a good alternative to tests that make some descriptive assumptions. So we can use in the example that we have discussed previously for the biomarker levels, the Wilson rank sum test to compare the data distribution and their median value. So if we were to encode these data in our program, then we would conclude that these data are consistent with the null hypothesis. This is also an example. And for the non-parametric test, if we were having continuous data that is not normally distributed, or the standard deviations are very different, then a non-parametric alternative to the t-test, known as the Mann-Whitney test, can be utilized. So this is also an example for the non-paired test. So to interpret the result, there is a statistically significant difference in the time to the platelet engraftment for patients who are receiving a graft from an unrelated donor when compared with a sibling donor. And similar to the previous test, the Wilson signed rank test, which is another non-parametric test, can be used to analyze the paired continuous data in situations in which we don't believe that the assumption of a normally distributed data is true. So we could apply this test to the example of paired data we saw previously, and the code performed in R would be as the following. So to assess the B values, it is higher than the conventional level of 0.05, and we would interpret this to mean that these data are consistent with the null hypothesis that the true median difference is equal to 0. So in summary, continuous data, there is paired and non-paired data. And if it was non-paired and normally distributed with similar variance, we would use t-test. If it was non-paired, non-normally distributed, or with non-similar variance or very small numbers, then we would use the Mann-Whitney test. And for the paired data, a paired t-test or Wilson signed rank test can be used. And for the categorical data, these are qualitative or categorical data that is best presented in the form of a table, such as that one variable defines the row and the categories for the other variable defines the column. So the data are arranged in a contingency table, and individuals are assigned to the appropriate cell of the contingency table according to their values for the two other variables. So this is an example of those table. And if we were using a chi-square test, then it is used to test whether there is an association between the row of variables and the column of variables. And when the table has only two rows or two columns, then this is equivalent to the conversion of the proportions. So the chi-square test can compare the observed number in each of the four categories and compares them with the numbers that are expected if there were no differences between the distribution of patients' gender. So the greater the differences between the observed and the expected number, then the larger the value of the chi-square and the less likely it is that the difference is due to chance. So to interpret these results, the proportion of sibling of two unrelated donors is different for the sibling and the female patients in specific. We also have the Fisher exact test, and when the overall total of the table is less than 20, or if it was between 20 and 40, with the smallest of the four expected value less than 5, then we should use a Fisher exact test. So the chi-square test can also be applied to larger tables, and generally it can be called an R multiplied by X table, where the R denotes the numbers of rows in the table and the C denotes the number of columns. So the standard chi-square test for two-row tables is generally a test to assess whether there are differences among the column properties. So when the categories in the columns have natural order, a more sensitive test is to look for an increasing or decreasing trend in the proportions over the column. So this trend can be tested using the chi-square test for trend, which has 1 degree of freedom. So in the table below is the relation between the frequency of C-section and the maternal size that is presented. So it can be representativeness of a causal relationship, but can reflect some indicator in general. So in summary, for categorical data, studies where there are two groups and the total number of patients is more than 40, in this case, we should use a chi-square test. Where if we had a study with two groups and the total number of patients less than 40, or even if it was more than 40 in a single cell that has less than 5, then we should use the Fisher exact test. In addition, if we had studies where there are more than two groups but not ordered, then we can use the chi-square test. And for studies that where there are more than two groups which are ordered, then we can use the chi-square test for trend. So when we are using statistical significant tests, there are countless statistical tests that are described in literature. So all of them can produce a p-value, which is a measure of how consistent the data are with the null hypothesis for that test. And most statistical significant tests can make some assumption about the nature of the data. And we should always be sure that we understand what these assumptions are, and always be sure that we understand what the null hypothesis is for the test that we are using. So having a low p-value indicates that the data are not consistent with the null hypothesis, and larger p-values indicate that the data are consistent with the null hypothesis. In addition, we need to use statistical significance tests sparingly and with care. So they are not a banker in medical research, as they can be and are very often overused and used incorrectly and inappropriately. Therefore, misuse and misinterpretation of the statistical significance test, in addition to the p-value, is very common in the medical literature. So here are some notes on the possible problem with the significant testing, and also some things that are commonly done with the significant test that shouldn't be done with any significant test. So multiple significant testing, one of the important things that can be or we should be cautious about is the overuse of significant tests. And for this reason, it is important to set out in advance which conversion will be made by the significant testing. Also, the statistical section of the protocol should specify the hypothesis to be tested and the extent to which the primary analysis is planned in prior that will contribute to the degree of confidence in the final result. Also, we shouldn't use statistical significant tests to compare the baseline data, such as gender and age. So once the data from a clinical trial are available for analysis, it is common practice to carry out tests of significance, assessing for the baseline homogeneity on the prognostic variables, covarieties, before producing the analysis to the effective treatment and outcome variables. Also, this practice is philosophically unsound, and there is no practical value and potentially misleading. Instead of its recommended prognostic variables to be identified in the trial plan and even fitted on an analysis covariance regardless of their baseline distribution. Also, we shouldn't use an insignificant test result to claim a no genuine difference. So it is a method only used to help in deciding whether there is a genuine difference between two treatments. And this is often what we want to decide when we are comparing the efficacy measurement. But sometimes, of course, we are really hoping that there is no genuine difference between the two treatments, such as adverse event on a new drug compared with an existing standard. Also, a statistical significant test, which gives a p-value of more than 0.05, cannot be used to support a claim that there is no genuine difference between the treatments. So, in summary, a statistical significant test is a method of helping to decide whether there is a genuine effect present in the data, as opposed to the alternative, which is that the data reflect only a random and natural variability in the quantity that is being measured. Also, many standard statistical significant tests exist, which are designed to test a specific effect, such as the differences between the means and the difference between the median and proportions. So choosing a significant test will yield a p-value, which tell us how consistent our data are with the null hypothesis of those showing a random variability only. We'll be taking a break now for Salat al-Isha and then continue our discussion.